diseases of the pleura. So everybody knows what the pleura is. So, the first one we're going to talk about is pleurisy. A more modern name for it is pleuritis, but we used to call it pleurisy. Basically, it's the inflammation of the pleura. And you know there are two layers of the pleura, right? The visceral and the parietal. It has a bunch of causes, right? Look at the long list. Toxins, drugs, cardiac, pulmonary embolism, myocardial infarction. So you know how you all understand. Toxins is easy to understand, right? They get there through the blood, right? Asbestos through the air. Drugs, again, through the blood, or even through the air. Many of these inhalers that we're using. Cardiac, pulmonary embolism. When a segment of the lung is dead, as in infarction, the overlying pleura will be inflamed, right? Everybody will respond to a dead person next to them. You will call 911, you will scream, oh, you dying. The body, the same thing in the body. When there is a dead portion, the surrounding tissue responds to it as something is wrong. It's like an inflammation. All right, so the overlying pleura will respond to a dead lung tissue with pleurisy, even in pneumonia. That's why you know that the lungs don't have pain fibers. Right. The only part of the lung, the respiratory system that actually has sensory fibers are the airways and the lung coverings. So the chest pain of pneumonia is not coming from the lungs. It's coming from the irritation of the overlying pleura. Okay. And then you have all these other stuff like pneumonia. We talked about that. Autoimmune diseases for the same reason. Gastrointestinal diseases like inflammatory bowel diseases, again, autoimmune basis, hematologic malignancy, sickle cell, and a bunch of iatrogenic causes. You know what is iatrogenic? Doctor-induced, right? Okay. So, so these are the causes of it. As you can see, the causes of it are many. So basically, most of the time, you just treat the cause, right? How does it present? Chest pain. But it's a different kind of chest pain because this chest pain is pleuritic because it's a pleuritic chest pain, right? Aggravated by deep breathing. That is so key. So if somebody has chest pain, the first thing you ask them is when you take a deep breath, does it hurt? If they say yes, then that means the pleura is causing the chest pain. And that could be because of pleurisy or something wrong with the underlying lungs. So I want you to be very clear. Pleuritic chest pain means pleural-based chest pain. It does not necessarily mean that the disease is in the pleura. The disease could be in the pleura or it could be in the underlying lung. Okay? So, for instance, the chest pain of pneumonia is described as pleuritic. Not because it's coming from the lung, but because it's coming from the associated pleural inflammation. Okay. And then, when you listen to the lungs, and in somebody that has dry cough is here and there, right? You can get dry cough, and dry cough is because of the cough receptors in the pleura. Okay? Cough receptors in the pleura. So there are cough receptors in the pleura. When you irritate the pleura, you trigger them, just like there are cough receptors in the airway. Okay? Okay. So you could get a dry, and it's usually a dry cough. Of course, dry cough means generally a dry cough tells you that there is nothing to cough up. Okay, if the airway is irritated by dust, for instance, you will cough, but you will not cough up anything. But if you have, say, bronchitis, say chronic bronchitis or even bronchiectasis, You have a wet cough. You cough up whatever is in the airway. But cough can be dry. And the cough in pleurisy is usually very dry. It's a dry cough. You don't cough anything. There is this thing called pleural friction rub. I've never heard it, but everybody say they can hear it sometimes. I've never heard it. Okay? It's supposed to be an inspiratory, leathery, squeaky sound. But it doesn't, the reason it's so difficult to tell from the rub of the pericardium is because it doesn't really rhyme with anything that you can track. The breath takes a long time, and it's supposed to be inspiratory. So you can understand that, of course, it's during inspiration that your lungs are expanding. That's why your pleura is stretched. So if there is any rub, it's going to be audible in inspiration. Okay? Diagnosis is very clinical. Treatment is again the treatment of the cause, and you can give NSAID to relieve the pain. Okay? I wanted to make you aware of how common, of some of the common causes of drug causes of pleuritis. Amiodarone. We use amiodarone a lot for AFib, right? Minoxidil. People use it for hair growth, even though it was developed for blood pressure control. The side effect was excessive hair growth. Now we use it for bald men, right? And yeah, you now monitor your blood pressure. And then bromocriptine we use for bromocriptine and methotrexate we use for prolactinomas, right? So, how did you know that?
I looked it up.
Okay.
I looked it up.
Oh, you looked it up. Okay. Good. Now, chemotherapeutic agents. Why am I showing you this? The reason I put this specifically in a box is because these are fairly common agents. In your primary care setting, you will see patients that will be on chemotherapy. You may not be the one giving them the chemotherapy, but you need to know that they're on chemo. I need to know what chemotherapeutic agent they're using. So if you are a primary care provider, it is not enough to say this patient is undergoing treatment for breast cancer with the oncologist. No. That is not enough. You need to be clear what agents they are using for that. If it's chemotherapy or radiotherapy, say it. Because if that same patient comes to you to complain of chest pain, if your note was not very specific, you won't even know what to look up. Could this be drug-induced pleurisy? If you never documented it, you will not know to look up that drug to see if it can cause pleurisy that your patient is presenting with. So it's extremely important that that's why I put that in a separate box of its own. And believe it or not, that is all about pleurisy. Any question on pleurisy? Okay, let's talk about pleural effusion. So, even though my definition is fluid accumulation inside the pleural cavity, the pleural cavity is the space between the visceral and the parietal fluid. Even though that definition, what is wrong with that definition? Say it again. Thank you. So that definition is faulty. The proper definition should have been excessive fluid accumulation. Because the pleural space is not empty. It has normal pleural fluid, right? So fluid accumulation is not sufficient. You just have to say it's excessive. The reason I didn't care too much about it is because normal pleural fluid does not accumulate. So if it's accumulating, it's already excessive, right? So if you say excessive fluid accumulation, it's like tautology. It's like saying it's going around the roundabout, right? Or reverse back. Okay. So, you all know about, I'm so sick of this anatomy stuff. You all know about pleural fluid and pleural effusion is excessive fluid accumulation. Now, there are some, like we said, Gia said there is fluid normally in the pleural cavity. So that fluid has a specific set of characteristics that you must be aware of. Adults they form normal fluid at a rate of about 0.2 mils per kg. So if I weigh you, I can give you an estimate of what your pleural fluid volume is. Okay? And if I am able to tap it, it's difficult to do, but if I'm able to tap it, I will see that it contains less than 1,000 cells per mil. Okay? You know that millimeter cube and mil is the same thing, right? Because the density of water is 1, right? So volume and mass is the same. Okay, just remember that. So, less than 1,000 cells per mil. And if you look at those cells, 60% of them are mesothelial cells. They are cells of the pleura that shed at the end of their lifespan into that cavity. 30% of them are monocytes, 5% are lymphocytes, and 5% are polynuclear cells. Pay attention, these are the inflammatory cells. They are not usual occupants of the pleural space. If you find them in excessive amount, there is an inflammation. If it's acute inflammation, it will be the polymorphs. If it's chronic inflammation, it will be the lymphocytes. You'll see. Lymphocytes and polymorphs are not in X. They are the least number of cells you find in normal pleural fluid. Okay? If you look at the pleural fluid chemistry, the pH of the pleural fluid is higher than the plasma pH. The glucose of the plasma fluid and the pleural fluid, they are about the same. But the protein level in the pleural fluid is definitely less than the plasma level, and it's about 1 to 2 grams per deciliter. Why is the protein level less? Maureen, why is the protein level less in the pleural fluid? Or even less anyway? Why is it less than plasma protein level?
Have to do with the pressure.
Exactly, because proteins are large molecules. Unless there is enough space for them to leave the circulation at the capillary level, they stay within the circulation. But if you have inflammation and you have endothelial contraction under the influence of all those inflammatory cytokines, then you create these big holes in the capillary beds that allow them to leave, right? So they usually go fine. That's why anytime fluid accumulates in any space, we test for the protein. If the protein is higher than what it should be, than in serum generally, we know that there is some inflammation responsible for it. Okay? And that is so important when you're talking about pleural effusion, for reasons that will become obvious in a few minutes. So this is what we're talking about here, right? This is the pathophysiology of pleural effusion, and Maureen already told you it has to do with oncotic pressure. So everything we talk about this in cardiovascular physiology, right? So whenever fluid accumulates in the pleural space, there are only 2 reasons for it. A couple of reasons. There usually be either increase in the hydrostatic pressure, or decrease in the oncotic pressure, or increased permeability of the capillaries. Those are the only 3 pathophysiologic mechanisms. Okay? It is either you're forming excessive weight through the hydrostatic pressure, you're not able to reclaim it at the venous end with the oncotic pressure, or they are just escaping through the capillary pores because they become wide as a result of the inflammation. Those pathophysiologic bases is actually the way we classify pleural effusion into exudate and transudate. When the pleural effusion is as a result of increased efflux of the protein through the capillary beds as a result of inflammation, that is an exudate. Okay? But if it is formed because of alteration in those tissue forces, either increased hydrostatic pressure or reduced oncotic pressure, and there is no inflammation, that is what is called a transudate. Okay? So, pleural effusion can come from two main pathologies, right? They're either transudate when they're due to increased excessive hydrostatic pressures. So when do you get increased hydrostatic pressures? When there is increased venous congestion, right? When do you get reduced oncotic pressure? Anything that makes you reduces protein in your serum, nephrotic syndrome, liver cirrhosis, right? Or malnutrition. They will take away your protein, your oncotic pressure will drop, you're not going to be able to reabsorb the fluid that is formed at the arterial end of the capillaries. So the fluid is going to reaccumulate in the tissue and will form, if there is a cavity, it will go in there. If there's no cavity, it stays inside the tissue. You call that edema, right? When it is within the tissue, when it's contained within the tissue. If it leaks into the cavity, like in the pleural space, it becomes an effusion. You can have knee effusion, you can have cardiac effusion, you can have pleural effusion, you can have... Effusion is not specific to the lungs. Wherever there is cavity and fluid seeps into it, it's an effusion.
Okay.
So you should be clear then on the excess. You know why there is excess. See how they spell protein? Did you see that? Okay, protein. That's terrible, right? I'm sure it's some NP person that is trying to make slides. Okay. All right. So fix that, please. You know, protein.
It's French. Huh? Okay.
All right, so let's talk a little bit more about more specific causes. I mentioned the definition of them already. Look at the causes of calcium. What are you doing? You have to jump over the chairs like that. Now you sit on the floor when you come back. So, we already talked about transudate and exudate, right? And I already told, so now you don't need anybody to tell you why there is transudate in congestive heart failure, cirrhosis, nephrotic syndrome, constrictive pericarditis, right? You understand exactly why that is the case, right? You may not be quite clear as to why there will be transudative pleural effusion in patients with peritoneal dialysis. Do you know what peritoneal dialysis is?
Mm-hmm.
Okay. Dialysis is when you go on dialysis when your kidneys cannot get rid of toxins. Right? There are two types. Hemodialysis, when they put a catheter through your neck or your groin, your arm, and your entire blood volume is taken out through this machine, and the machine cleans it, filters it basically of toxins, and returns it into you. That is hemodialysis. Another way you can do that is to actually put a lot of fluid of specific composition into the peritoneal cavity. And because the omental surface is a huge vascular thin surface, when you put the fluid in the peritoneal cavity, the fluid, because it has a specific composition that allows some things to go into the blood and allows some things to come out from the blood, that fluid is left in the peritoneal cavity for about 4 hours, and then it equilibrates. Everything will diffuse. molecules move from areas of higher concentration to low concentration all the time. It's called diffusion, right? So once you put it in the peritoneal space, substances will equilibrate. Toxins will diffuse into it, and some glucose that you put in it will go into the patient, right? And then after 4 hours, you drain it. When you do that, that is peritoneal dialysis. Okay, it is easy for you to understand now how that can be associated with pleural effusion, because actually the reason, but that does not explain why there is pleural effusion, right? You know why there is pleural effusion when you do peritoneal dialysis? When you have excess volume in the pleural space. What I'm sure they didn't tell you in anatomy and even pathophysiology is that there are holes in the diaphragm. They are not anatomic holes. You don't see them when you see the diaphragm, but they're there. They are very microscopic holes. Did anybody tell you about that? Mm-hmm. There are holes in the diaphragm. The man that discovered them is from USC Medical School. His name is Lieberman. So they are called Lieberman holes in the diaphragm. They are microscopic spaces. And if there is enough fluid in the peritoneal cavity, that fluid can literally leak through the diaphragm into the chest. Okay? And when it does, it tends to do so more on the left than on the right. Can anybody tell me why that is the case? Exactly. The liver is huge and it protects the right hemidiaphragm. Spleen is small and it's in the corner. So those holes are more accessible on the left side. Okay? So remember that. Lieberman holes. Okay? So now you understand why you have all this. Of course, atelectasis will give you transfer. You know why that is the case, right? Because once the lungs collapse, you create a negative pressure in the space. That negative pressure sucks that fluid into it. Right? That makes sense, right? Good. So that's why you have atelectasis can cause it too. And pleural effusion, again, see pleural capillary leak, you can get it in hypothyroid.
That's you.
That's you. All right. So now look at the X-rays. Parapneumonic. Parapneumonic means alongside pneumonia, TB, connective tissue diseases, malignancy, subphrenic abscess, infections, and pulmonary embolism. You know the pathophysiology for all this is all based on inflammation, right? Good. Now there are some unique pleural effusion that you need to know about. Urinothorax is usually found when there is obstruction to urine flow. We call it obstructive uropathy. Okay. The obstruction could be at the urethral level, like in men from developing countries that have had gonorrhea and they didn't treat it. So if you had gonorrhea and you went to a Santero instead of going to a clinic, your gonorrhea is going to heal, but you're going to end up with a scar. You're going to end up with a scar in your urethra. When you end up with a scar in your urethra, you're not going to be able to pee easily because the urethra is narrow. You have to push. And that pressure will keep backing up into your bladder, into your ureters, ultimately into your kidneys. You get what is called obstructive uropathy. It could happen at the level of the prostate, like in benign prostate enlargement, right? Or even prostate cancer. Because the urethra travels through the prostate. So if the prostate is abnormal in shape or size, the urethra can get constricted and the men will have obstruction. Sometimes it could be because the ureteric openings into the bladder, there may be a bladder polyps, for instance, that is close to the entry of the ureter into the bladder and cut off that ureter. The kidneys are still filtering urine into that ureter, but the ureter cannot enter into the bladder, so the urine backs up. So you can get obstructive uropathy from many places. I mean, if you keep pinching the head of your penis when you're peeing, you're going to end up with obstructive uropathy. For you guys, just pay attention.
Sure, bro.
So you see, it can, so many ways you can get it. Then once you have urine backing up and now leaking into your chest, that is called urinothorax. Okay?
causes.
Did you say?
Why is everybody sneezing? If I leave this class and sneeze, I'm going to sue every single my name. You'll be named on the lawsuit.
Yeah. Hey, Dr. Martins, could you repeat the last thing you said about it going to the chest?
Yeah, urine, once you have, honestly, that one I can't explain to you. I only know that once you have obstructive uropathy, you can end up with urine in your chest.
Wow.
It's called urinothorax. We have not figured out how that happens.
But it does.
And
Okay.
you know how you know
No,
how
I
you
don't know how it happens. I don't know. No, my question is, I'm guessing it's pretty rare because I would think that they would get a UTI before, they would get symptoms of a UTI before any of the backup would happen.
Well, the thing about it is, you know, you're right. They will get a UTI, but again, it depends on the level of the obstruction. So what is UTI? Urinary tract infection. Well, urinary tract begins in the feces, in the kidneys. It could be a urethritis, it could be a cystitis, it could be a urethritis. So whenever there is stasis, there is bound to be some infection. They will be symptomatic, but the truth of the matter is that you don't consider obstructive uropathy in everyone that comes to you for UTI. Generally for men, we just treat UTI, we leave them alone. Women have more frequent UTIs for obvious reasons than men. When a man comes to you with more than 3 UTIs in a year, you begin to wonder there is something going on here, right? For a woman, it's not news, right? And so there will be UTI, but you will not look for obstructive uropathy in everybody with a UTI, unless it is recurrent, right? Yeah. So that is urinothorax. And then if somebody has a blunt trauma, a blunt trauma to the chest, and they rupture a blood vessel, they can bleed right into the thoracic space, right? And that is called hemothorax. And then sometimes when you have lymphedema, lymphatic obstructions, right? So a tumor, whatever it is, obstructs a lymph vessel. The lymph that is supposed to be going back to the venous side will now leak into the thorax, right? And you call that chylothorax. Lymph is chyle, okay? So chylothorax. It could be congenital, it could be post-traumatic. If you rupture the thoracic belt, for instance, you can end up with chylothorax. So, urinothorax, hemothorax, and chylothorax, they are special categories of pleural effusion. They have nothing to do with the pathophysiology of X-linked cancer. Okay? That's why they're put in their own special categories. And then there is even a rarer, more special categories of pleural effusion. Meg syndrome. You know, in the early days, the fathers of medicine, they like to name things. There is something about human beings. We like to name things. It's in us to name things. You go to kids in kindergarten, they call themselves names. We like to name things. Even adults, they call people names. Adam named everything. We're still naming things. So the fathers of medicine, whenever they discovered anything that didn't have a name, the first thing they do was to name it. And many times they name it after themselves. Right? So Meg syndrome is a syndrome discovered by Megs associated with benign pelvic neoplasms that is causing ascites and pleural effusion. Now, it is not specific whether the ascites leaked into the chest or the tumor is somewhere obstructing lymph. The pathophysiology is not clear. Why is it here? Why is this news? The reason this is news at that time was because it's a benign pelvic tumor. So the impression you will get if you encounter pleural effusion in somebody with a pelvic mass is to say, oh my goodness, you have cancer. Right? And then you go and you look and it's an ovarian cyst. So that was why it merited the name. You know, so it's like, don't get scared. It could be benign. Okay. So Mac syndrome. And there's another one that is even much more rare. Yellow nail syndrome. People who have nails that look like this. Natural nails, okay? Not when your patient is painted like this. People paint all kind of crazy nails these days. You know, I used to have this patient. She had this nail polish, right? And she's still my patient. She's my patient for about 15 years. When she was much younger, she was a wild woman. With these nails, right? And on those nails, I don't know how they do it, but every time the nail dries up, it's usually some sexual position, right? And it's a nail. And then when she comes, and I was much younger then, right? And when she comes to see me, it's like, Dr. Martins, oh my goodness, I'm so... She's talking to me and she's showing me all this crazy stuff. I just look at her like, really? But it's got to be... Did I tell you about my patient that said to me, Dr. Martins, you ejaculate a lot.
What?
You know what I'm talking?
What?
I use my hands like better look, right? So she looked at me and said, you ejaculate a lot, don't you?
What does that mean? Yo.
She was like, oh, I'm sorry. Gesticulate. I'm like,
Okay. No, it's on your mind.
So yellow nails,
Wild.
natural nails, okay? And then this is lymphedema. You know why lymphedema is different from peripheral other edemas? We call it lymphedema because it's an edema of the lymph. It's usually non-pitting. So if there is edema that is non-pitting, most of the time is a lymphedema. And the reason it is non-pitting is because remember that lymph is not just protein, right? It's also cells. Cells that are alive, that can produce fibrin and all that stuff. So when lymph accumulates in a place, those cells, they form connective tissue. So the space is not just fluid now, it's now also tissue based. Everything becomes thick because the tissue is now thickened because of all this extracellular matrix that is laid down by the cells. So lymphedema tend not to be pitting, unlike regular edema that is pitting better than lymph. Right? So very important that you understand that. And then there is this entity they put here, pseudocylothorax. I've never seen it before. It's a chronic condition with elevated cholesterol and pleural fluid, whatever that means. You can white it out right now. Because I think, I don't know, I've not heard about it. I've not read it in many places. I don't know how important it is, but I won't be the one asking you anything about it. I've not seen any question on it. Pseudocylothorax, whatever that is. False chylothorax. I would imagine how it came about is usually with chylothorax, it's a very bad thing. It's either congenital or post-traumatic or even malignant. When you have malignant metastasis that obstruct the lymph vessels. Now, if you end up with a chylothorax without obstruction of the lymphatics, you can call that a pseudochylothorax. Because the way we recognize chylothorax is elevated cholesterol. That is the chemical signature of chylothorax. Is you tap the pleural fluid and it has high cholesterol in it. Okay?
Dr. Mark, could you say about lymph? I didn't understand.
Lymph?
Not feeding or
Non-feeding.
non
Feeding. As in a pit. As in eating. Eating. You know how pedal edema will beat when you put pressure on it? Lymphedema is So how does it pilot?
Just wrote it very hard.
I didn't hear anything about that. Okay, so pleural effusion, how does it present? It depends on the amount. It is asymptomatic when it is less than 500 mils. So you can actually have up to a pint of pleural fluid excess and not know it. It will be an incidental finding. There will be no sign, there will be no symptom. It's completely silent. In that case, only the symptoms of the cause of the effusion will be obvious. Of course, there will be pleuritic chest pain, with or without dry cough, from the associated pleurisy. There might be fever, there might be chills if there is infection, but the effusion itself will not have any signs or symptoms. You got that? When the effusion is more than 500 mils, it is clinically obvious. What are the signs? Shortness of breath. That is the key. Of course, along with that will be the pleuritic chest pain of that effusion. But there is something strange about the relationship between the shortness of breath of pleural effusion and the pleuritic chest pain. I'll get to it in a minute. As the amount of effusion increases and the pleural fluid is splitting the viscera from parietal pleura, the irritation that you get when the inflamed pleura are rubbing together, that is responsible for the chest pain, subsides. You understand what I'm saying?
Yeah,
right?
so
Remember I told you that the reason you get the chest pain with pleurisy is because of the inflamed pleura. And because that inflamed pleura gets stretched and rubs, the viscera rubs against the parietal in inspiration, the chest pain tends to be pleuritic. If you get effusion, right, and the pleura are now separated, they're not rubbing against themselves again, the pleuritic chest pain tends to become less as the patient becomes more shorter. Okay. How do you know the amount? What of it? That information is not supposed to be interpreted as, you are not supposed to measure the amount to find out if it's symptomatic. No, it's supposed for you to be able to interpret the symptoms within the context of what you know as the baseline. If the patient is, if X-ray shows pleural effusion and your patient is completely asymptomatic, generally speaking, that means it's less than 500 cc. Okay? Okay. When the effusion is large, that is more than 500 cc, you will get shortness of breath and tachypnea. But those are really not specific. They don't tell you anything. You can get respiratory distress in pulmonary edema as well. You can get tachypnea with anemia. Okay, so that's why I call them non-specific. When you examine the chest, over the area of pleural effusion, there will be absent or reduced chest wall movement. You know how to do that, right? Good. There will be absent or reduced breath sound, no breath sounds. Okay? In order for you to auscultate the breath sound from the chest, the visceral pleura must be in direct contact with the parietal pleura. That's the only way the sound travels. You can never call to your neighbor under your pool. It doesn't happen. You won't be able to sound, even if you have a speaker there, sound won't travel. So, breath sound is completely absent. You know vocal and tactile parameters, you know what that is, right? They're absent. When you percuss, it's stony dull. You know the difference between stony dullness and regular dullness? That's not so. That is stony dull. See that deep Take this way. Yeah. That's normal. That is stony dull. Stony dullness is the kind of dullness you get over muscles. Right? Okay, so that is the sign that you see with pleural effusion. And then you do x-ray. Anytime you're thinking of pleural effusion, you have to do just x-ray. Okay? When the effusion is really small, why is this thing here? Really, can you get this thing out of here?
Let's push that button.
Thank you. Thanks. Just throw it in the outside. All right. The earliest sign of pleural effusion on chest x-ray is the blunting of the costophrenic angle. See what a normal costophrenic angle looks like? It's clear and pointy. When you lose that, there are only two reasons. Either the two pleura are now attached and fibrosed and stuck together, or there is fluid separating them. So the blunting of the costophrenic angle is the earliest radiographic manifestation of pleural effusion. In order for you to see that on chest x-ray, you must have at least 150 to 200 mils of fluid in the pleural cavity. Okay? So, stop writing and listen to me. Blunting of the costophrenic angle is the earliest radiographic manifestation of pleural effusion. But the pleural cavity can contain as much as 500 cc of fluid, and the chest x-ray will be normal. Okay? Because the pleural cavity is a convoluted, contorted space. The fluid can be there and will not be apparent on the x-ray. So remember that. Okay? As much as 500 cc of pleural fluid can be present in the pleural cavity without apparent changes in the frontal view of the x-ray. Okay? Yes?
So, what you're trying to say is that Bell requires up to 300 for you to see that. You can have 200 mistakes.
Thank you. So, you know, like, that just, again, reiterating the fact that you never say never in medicine. It's usually there, but it's not always. Okay? The whole thing is frozen. The computer is.
You think it's because you touched the smart screen?
Yeah, is it because we moved the.
There you go.
Okay. You have the magic touch, man. All right, so remember I told you that. Oh, come on. I told you that there are two reasons you could see this. It could be because of fluid or fibrosis. When the visceral and parietal pleuras are fibrosed, thickened, and stuck together, you will see that. Clinically, how do you tell those apart? That is why we don't assume that is the case until we do what is called lateral decubitus x-rays. Why do we do lateral decubitus? Lateral decubitus x-rays simply allows us to show that the fluid flows. If the fluid flows, then that means it's a free fluid within the pleural cavity. That's why we do lateral decubitus x-rays. So when you see blunting of the costophrenic hand, now order most of the time, radiologists will do a lateral decubitus immediately. But sometimes if cost is an issue, they're not sure it will be paid, they will just send you the x-ray with the blunting of the costophrenic angle. You now have to go back and say, can you do a lateral decubitus? Because I need to know if it's a free flowing fluid. Now, if you do a lateral decubitus, you see the fluid layers out like this. But is that always the case? There are times the effusion will be like this, and the patient will lie down on this side, and it will not layer out. When there is effusion that does not layer out, then, and you still think it's an effusion because your clinical signs are telling you there is an effusion there, but it does not layer out. Can anybody tell me why there will be free fluid that won't layer out? Thank you. When the fluid is such a gunky, inflammatory fluid that is really pus in there, right? When it is really an empyema, right? An empyema is pus in the pleural space. But generally, the way we describe it, we don't call it empyema because it didn't layer. We say it's a loculated effusion. Okay. So we say the effusion is loculated. I'm going to write that. Is that this? Oh, okay. Yeah. Right, this is very area. Loculated for effusion. If you see loculation, you're not, in your primary care physician, you're not going to be the one that will treat that patient. You just have to set them up. Okay? So very important. It's a good thing now that you guys are thinking about how to do ultrasound, because with ultrasound, you don't even need to do the lateral decubitus. You can identify fluid that is not layering up with ultrasound, bedside ultrasound. I'm sure Katie would. You guys will do a lot of that in the let's do.
Are we doing that next month?
Yeah, in the surgical lab. We just got this. Talia told me about this mannequin. Is a simulation guy. We need a name for it. You guys should name it. When I come
So we're gonna do it Martin's.
And the guy has all these crazy programs that allows you to hear all kind of murmurs. So we're thinking that we can actually introduce that into part of your physical diagnosis exam, set it to a particular murmur, maybe mitral stenosis, whatever, and put a stethoscope there. So you guys rotate through different tables and you listen to write your answer. The guy is it should be arriving in about a couple of weeks or a month. But it's a cool stuff.
That's what's up.
Yeah. When I heard about all that, we need that. All right. And then Katie just got this stuff. That is like voodoo, man. It's a chip, right? And I can take it and put it on you. And ultrasound of your abdomen will show gallstones. That's why I call it voodoo. It's a little chip. So it allows the physical diagnosis class and all these emergency labs to be really fun. Because you can put a hepatomegaly chip on one of yourself and you do the ultrasound and you see it. So medicine is becoming really fun to me. Anyway, you see that. But I really think you should name that guy. All right. So once you diagnose effusion and it layered, that means you can suck it out, because that means it's free flowing. If you can demonstrate that it's a free flowing fluid, then you can do what is called a diagnostic thoracentesis. A common name for it, the emergency room will call it pleural tap. Internet will call it diagnostic thoracentesis. All right. Generally, you use a very large gauge needle, and you know these needles, right? I show you. The smaller the number, the bigger the needle. Okay. So, if you want to give an injection to somebody who's messing with your girlfriend, tell him, when you go to the emergency room, tell him you're used to 18 gauge. Right? So you use a 18 gauge needle and you mount a 50cc syringe on it. And if you have ultrasound, we didn't have ultrasound when I was in training. You have the patient sit like that. The reason you have them sit up with their palm up is because that opens up the intercostal space, right? And then you percuss the upper body of the fluid. And generally speaking, because it's a diagnostic thoracentesis, once you identify the upper body of the fluid, you go one intercostal space below. Because you just want to take a lick. If you're trying to do a therapeutic tap, then you go to about the lower, you go into one intercostal space above the lower limit of the dullness, so you can get all the fluid out. All right. When I was in Nigeria, that was what we did because we didn't have ultrasound. We went by tapping and sticking needles and stuff like that. So when you're doing this, remember, you remember anatomy, right? The neurovascular bundle, the intercostal neurovascular bundle, where do they travel? At the lower border of the rib on the inside, right? That is why when you're doing this thing, you go above the rib. You must identify the rib clearly and go above it. If you disregard that simple fact, you will convert a simple pleural effusion into a hemothorax, and heaven help you. Remember, that space can hold up to 500 cc. That means your patient can bleed into the thoracic, into the pleural space, up to a pint of blood. So, very important. And that question is everywhere in the exam. You go above that, the rib, and you obtain, in a diagnostic thoracentesis, you obtain enough fluid for analysis. Because it's not therapeutic. If it's a therapeutic synthesis, you drain as much as you can. And generally speaking, to protect yourself. That really is why we do it. But the reason we say to everybody else is to see if we hurt the patient or any pneumothorax or something like that. It's to really to protect you. Because two complications of pleural tap, pneumothorax and hemothorax. Because if you puncture the lung, so you think you're putting your needle into fluid, but actually it's lung tissue that is there, and you put your needle right through it, you're going to cause pneumothorax. So since pneumothorax was not on the X-ray that showed the effusion, if you do a post-tap chest X-ray, you will see the pneumothorax. So you know, oh my goodness, I got screwed up. When you call somebody. It's not a big deal, it happens. That's why you in the consent, you tell the patient, I'm going to do a tap. Generally, it's a safe procedure 99% of the time, but there will be one in 10 or 20, 100 people that will have bleeding or they may have air leak in their chest. They sign the consent, and then you do it. These days, we're still teaching these because you don't know where you find yourself. You might find yourself in rural area of Aruba.
Oh wow.
Right? And then, so you might need to do this. But in the United States, does not matter. Even in the Appalachia, you have ultrasound. Okay. So at the end of the day, what do you care about that fluid? You want to know, is this a transudate or is it an exudate? That's all you care about. If it's transudate, if it's exudate, oh. Okay. That parameter or that criterion that we use to determine if the fluid is transudate or exudate was developed by a guy called Light. His last name is Light. And he showed the light in 1972. Light said, if you do a tap and you look at the fluid, you measure the protein and you look at the LDH. If the ratio of the fluid protein to serum protein is more than 0.5, in other words, there is a lot of protein in that fluid that is more than 0.5 of what is in the serum. Or the LDH in the fluid to serum LDH is more than 0.6. Or the LDH level is above the filtered upper limit of normal. That is an entity. Okay? You'll ask me, why do we need criteria? I mean, if transudate are generally due to cardiac, liver, kidney problems, shouldn't that be obvious? Well, that's what we all thought. But remember, just because somebody has heart failure does not mean that they cannot have pneumonia. And it doesn't mean that they cannot have a parapneumonic effusion. So if you have somebody in admission for CHF exacerbation who went into CHF because they developed pneumonia and became hypoxic, right? And then went into CHF. And now they will present to you with CHF as a result of pneumonia. There is a possibility that that pneumonia could have a parapneumonic effusion. How do you now tell that effusion from the effusion that you normally get in some patients with CHF versus this effusion is because of the pneumonia? How do you tell that apart? That can be a clinical nightmare, right? Because one, you will just leave and treat the CHF. The other, you have to treat the pneumonia, monitor the effusion, drain it if you have to. That is why this light criteria was so appreciated when it first came out, and it worked. I mean, look how good this criteria is. 98% sensitivity, 83% specificity. That is how good that criteria, just those two criteria are. So that's why we kind of needed this type of things to help make sense of it. All right? So again, transudate, exudate, superficial rupture here now. Okay. It wasn't on the previous courses and stuff like that. All right, so don't think I'm repeating myself. I'm not. When I saw that, they mentioned the superficial rupture, which is definitely because of pleural effusion, right? So don't forget light criteria. Just remember 0.5 and 0.6. LDH is 0.6 ratio, and it's always the fluid serum. Not serum fluid. Fluid serum. Sure. Fluid first. Remember, fluid first. Fluid first. So, you really cannot do much without tapping a pleural effusion. Everything you're going to do is dependent on the result of that. So, if the results show that the patient is transudate, you're done. Just click the cause. Nephrotic syndrome, cirrhosis, CHF, send the patient home. The only time you do anything else is really if it is symptomatic. Okay, if the patient is like severely short of breath, then you relieve the shortness of breath by just doing a therapeutic tap. And once that is done, send them to nephrology, cardiology, or gastroenterology, depending on what the cause is. Okay. So other than that, you're fine. You don't do anything else. When it's an exudate, then you need to look for the cause of it. Then light criteria will help you say if it's an exudate or a transudate. But I hope you realize that if you're going to need to compare the fluid protein and LDH to serum protein and LDH, that means you have to draw the blood at the same time, right? Mm-hmm. The commonest mistake interns used to make, and they get chewed so badly, is to do a tap and then forget to draw a comprehensive metabolic panel and look for LDH and protein at the same time in the blood. So we're looking at a tap that was done today, and we're looking at a comprehensive metabolic panel that was done when the patient was admitted 3 days ago. I mean, it doesn't really make a big difference, but I used to chew incense up for that because that just shows that you're not thinking when you're doing the test. Okay, so you should really know that you do both at the same time. Okay. And then, even though you order all these standard tests, okay? They measure glucose, they measure the cell, they culture it, and they do all kind of markers for specific diseases. You generally don't order all the possible markers. What you do is you draw the fluid, you decide if it's an exudate or transudate. Now, once you decide it's an exudate, you now go back and talk to the patient, dig more, go into your history, dig more for what is it likely to be. Then you now ask the lab to do those tests based on your clinical suspicion. If you do all the possible special tests, you will be so expensive. Your care will be so expensive. Okay? So, pleural fluid pH correlates well with pleural glucose levels. So the cause of low pleural pH and low pleural fluid glucose are essentially the same. Why am I saying that? It is a hell of a lot more expensive to measure pleural fluid pH. Okay, it's a lot easier to measure the pleural fluid glucose. So if you are in a place where you can't measure pH, do glucose. They're highly correlated. Okay. And why are we interested in pleural fluid glucose? Because if pleural fluid glucose is low, look at what you're looking at: malignancy, bacterial infection, rheumatoid pleuritis. Those are big deals. Okay. Remember, in your encounter with patients, you really want to identify what will kill my patient. Your goal is to prolong their life. So low glucose, malignancy, and bacterial infection, big deal. Because you can't miss that. That means if your patient has low glucose and you don't find bacterial infection, it's not over. You have to keep looking until you find that cancer. Because not all cancers are obvious. If you don't have any diagnosis after you've done all these special tests, stainings and markers, then you begin to look for other causes. Like maybe this is not a pleural-based problem. Maybe it's a lung problem that is just presenting with a pleural manifestation, like something like a pulmonary infarction. So you will do a spirometry, yes?
For the pleural glucose, does eating have any effect at all?
No.
I mean, just like eating.
So we're talking pleural.
Just in there.
Well, if you dump soda in your thorax, yes.
I don't know.
Yeah.
But what you eat, put in your mouth, ends up in your portal venous system, ends up in your liver. Liver takes care of it. For the first 2 hours, it might go into your blood and be high, but within 2 hours, the cells have tucked it away, and your blood glucose is down to normal. I'm talking about fluid in the glucose in the pleural fluid. You know, so that usually the glucose in the pleural fluid should be. So that question is not as simple as I thought about it, because you're right. Pleural fluid glucose approximates serum glucose at all times. So if somebody with, say, breast cancer that is not yet diagnosed present with pleural effusion, right? But they present with the pleural effusion after they've eaten, right? Their serum glucose will be high. The glucose in that pleural fluid will equilibrate to that high glucose level. And that can actually mask the low glucose you would have seen as a result of that underlying cancer. So it's a good question. Yeah, that is the only thing. Other than that, if the serum glucose is high, the pleural fluid will be high. So what does that really tell us this morning? Believe me, this is the first time that has been said in any class, any group of care providers that I've been in. And I've been in so many settings, but nobody has thought about this. Because you know what that really means? What that really means is that it is extremely important if you're going to base any decision on pleural fluid glucose level. It's important then to know, is the patient diabetic or did the patient just eat? Because just because the glucose is not low, if the patient had just eaten, does not mean it couldn't be malignancy. All right. You do markers for TB and you treat TB, whatever you find. Symptom improving, you watch the patient. If you cannot find anything, you see an exudate and you can't find anything, you must biopsy the pleura. When do you biopsy pleura? Exudative pleural effusion that doesn't have an established cause. You do not biopsy. You don't do anything in transudate. Focus on the cause. Exudate, you can't find the cause from the fluid, you must biopsy the pleura. There are some clues you can get from the cell analysis. Pleural fluid neutrophilia, that is neutrophils more than 50%. Remember, neutrophils are less than 5% of the cells in the normal pleural fluid, right? When they are now 50% or more, you got issue. That is pleural fluid neutrophilia. You will see that in the parapneumonic effusion, especially if the pneumonia is a bacterial pneumonia. You will see it in pulmonary embolism. You will see it in pancreatitis. Why, David? Why would you even see pleural effusion in pancreatitis?
It's affecting the pancreas's ability to release enzymes.
So how would that cause neutrophilia? Say it again?
Causing massive inflammation.
Exactly, contiguous spread of the inflammation. Remember, if the pancreas is high, retroperitoneal. So at the diaphragm, you've seen the diaphragm in cadaver, right? You saw that diaphragm, it might be here, but in the back, the diaphragm sinks low and it covers the pancreas. So when you have like a while the pancreatitis, like pancreatitis, right?
Thank you.
What are you doing, man?
I'm trying to plug my laptop.
All right, so you know when you have the pancreatitis, very aggressive, angry pancreatitis with bleeding, the one that will give you the calling and Turner sign, remember those signs? Right, those ones, that is like a wildfire. It doesn't take anything at all for it to implicate the diaphragm and go and affect the pleura. So you can get pleural effusion, and it's a very bad prognostic sign in somebody with pancreatitis. Pleural effusion in a patient with pancreatitis, high rate of mortality. Okay? So it's contiguous spread of inflammation, like Stephen said. Right? So then, of course, subphrenic abscess. You know that is easy, right? The abscess is above the liver, right? But below the diaphragm. Same contiguous spread. Right? So once you see all that, neutrophilia, you look for this type of causes. Pathology is above the diaphragm, pathology is below the diaphragm. That might be irritating the diaphragm, okay, and implicating the pleura. When you have pleural fluid eosinophilia, the eosinophils more than 10%. You are not even supposed to find the eosinophils in the pleural case. Remember, the two cells, inflammatory cells we find in the pleural cavity are lymphocytes and polymorphs, not eosinophils. So that is why you don't need up to 50% eosinophils, you only need 10%. If 10% of the cells are eosinophils, you've got a problem. You're going to be looking for allergy or parasites. For some weird reason, hemothorax that is a result of infarction or blunt trauma gives you eosinophilia. I can't explain it. It's one of those things just happen. Okay. Of course, drug-induced allergic effusion, parasites like paragonimiasis, fungal infections like endemic mycosis will give you pleural fluid eosinophilia. Now, when it's the lymphocyte, you're looking for chronic infections like TB, malignancy, chylothorax, connective tissue disease, yellow nail syndrome. So you see these cells, they can help you characterize what you're dealing with in a patient with infusion. And then something that we also do, especially if you're taking some significant amount of fluid, is to actually take as much fluid as you can and then send it for cytology. So when you send it for cytology, they drain it, seal it, and look under the microscope, and they're looking for malignant cells. See how much the yield is, 60 to 90%. It's more like 60 than 90. Okay? The yield depends on the extent of pleural involvement. Okay? Of course, you would imagine that the cytology yield will be higher when the pH is less, right? Right? Because low pH means low glucose. Low glucose means more cells are eating up the glucose, right? So you can understand why low pH is going to tell you you're likely to get a higher yield if you do cytology. Okay? Cytology is just examining the cells, specifically for malignant cells. All right? Now, remember, when a fusion is bloody and you tap it, preserve it, put it in an airborne container, or else it will clot. If it clots, the lab will not be able to use it. You have to go back to the patient. You know how fun it is to stick needle in somebody's chest? No one ever make that mistake. If it's a bloody effusion, you put it, you store it, you heparin, and I'll give you the amount of heparin. Usually, in many hospitals these days, they have heparinized containers, like they have heparinized test tubes. You can use to do this. You just have to remember. Many people don't remember. And the lab will tell you, unable to perform sample plotted. You go and explain to your patient, actually, I forgot. The guy will just turn his back at you. Yes.
Is it possible to confuse a traumatic tap with a nuclear?
Not really. Because if you're sure of your technique, to start with, you shouldn't have traumatic. But let's say the patient is morbidly obese and you really couldn't feel the ring convincingly or identify the border, and you trusted the needle in blindly, and you hit an artery, you will see the blood, it will come out like this in spurts, right? You know, this is an arterial bleed. If it is a vein, it will just drip. If it is pleural fluid, it is not frank blood, it's blood stain. No amount of pleural fluid, unless there is frank hemothorax, it's not whole blood, it's yellow blood mixed with something. So it will be faint. You know, but this, everything I just told you, they help. To tell a traumatic tap from hemothorax is the quantity, because if you hit a blood vessel, whether vein or artery, the blood will clot after like 2-3 minutes in the syringe, unless it's an arterial bleed and it's significant. Did I answer your question? So look at all the tests that you can do to help you figure out what is going on in the patient with chronic infusion. If you know your patient has pancreatitis or vasopressor rupture, you measure amylase. Amylase level will be high in that fluid. If you think your patient has cardiothorax, you measure lipids, cholesterol, and triglycerides in that fluid, right? And I'm giving you the values of it. If you think your patient has Frankfurt from empyema, you centrifuge it. And you see the cells, pus cells, go there. If you're thinking your patient has TB, you can do PCR for the bugs, or even strep. You can do PCR looking for TB or strep pneumonia, right? You can do all kinds of tumor markers. If you're really worried that this could be a traumatic time, do a hematocrit. Right? Spin it down. And normally hematocrit is about 40%. So if you come that hematocrit is 10, and your patient is not short of breath, you know this is hemothorax, not a hematocrit. Okay? That's a way more specific. Okay. And then, if you're thinking TB, you can do interferon. It's a cytokine. If you're thinking it's urine, do creatinine levels in this stuff. If you think it's an X-ray from heart failure, do BNP. Right? Because heart failure is the volume of the BNP will be high. If it is causing the blood region, BNP level will be high. If you think it's a connective tissue disease, look at the complement and it will be reduced. Okay? So you don't order all of this. You order what will help you make a diagnosis based on your clinical suspicion. Okay? And none of this is new. This is not a complicated table. You don't need anything on this side. Everything you need is here. Okay? You should know that amylase comes from the pancreas and saliva. That's it. That's where it comes from. So if this level is high in the fluid, it's because the patient has a pressure rupture or pancreatitis. That's it. You all know that cholesterol, just told you, lymph is a lot of cholesterol. You think it's calories? No lipid profile. Look for the cholesterol and the triglycerides. All right. So I don't want you to think, oh, this is one long big table. This is nothing. It's a lot of nothing. The most important part of this table is everything on this side. And you know where they are all from. We talked about this. Even my grandmother knows that if there is creatinine elevation, you should look at the tables. Right? Isn't that true? That table is not as complicated as it looks. All right, so when you diagnose the fusion and it's not a transudate, it's an exudate, you have to address it. Then if you have to address it, what are your options? Well, you can put a pleural catheter there, chest tube, and you will do chest tube. Really will teach you how to do chest tube. Right? And you drain it, and you leave it in there until it stops draining, and then you take it out. Okay. The good thing about draining is that once you drain, the lung will re-expand. Remember, the effusion, when it's significant, it tends to collapse the lung. Okay. So you drain it, intermittent of drainage of excess fluid through a catheter that remains in space, right there. Or you can keep sticking needle in their chest and draining it. Okay, you do it now, you come back 1 week later, you do it again, just like you do acidic tag, right? For liver cirrhosis patient. Bad thing you have to do sometimes to save your patient's life. Okay? So you can do the same thing. Repeated fluid removal via syringe or temporary external catheter connected to the vacuum container. When the effusion keeps recurring, keeps coming back, especially when it is when it's an accident and it's due to a terminal illness like cancer, then you have to do what is called pleurodesis. Pleurodesis is a terrible procedure because what you do in pleurodesis is you drain the fluid and then you look for a very terrible irritant, something that will irritate the pleural surface. And then you introduce that irritant into the pleural cavity. And it's going to do exactly what you think it will do. It will irritate both the visceral pleura and the parietal pleura. They will be wildly inflamed, and they will come together, and they will heal together. They will stick together by fibrosis. And by fibrotic adhesion, the pleural cavity in that space is obliterated. It doesn't exist anymore, so the fluid can't reaccumulate. Mm-hmm. So when you obliterate the pleural space by causing the visceral and parietal pleura to come together in a fibrosis, that's what we call pleurodesis. Okay?
Dr. Barnes?
Yeah.
How does that affect their breathing? Because the fibrous tissue wasn't as expansive, so.
Remember that you drain the fluid.
Yeah.
So let's take it. Let me draw it for you. You just what it has. That's my hand. All right. So we're going to look at this pneumothorax right here. So that's your lung, and Your visceral pleural greater pleura, right? And this is your lung. So this is pleural space, right? And then you develop a fusion, right? And when you develop a fusion, form fluid here, right? Now you become short of breath because the lung is getting squashed. And then you drain the effusion. And your lung relax.
But would
Right.
the fibrous tissue that you make not be as elastic?
Just one more time. Right? So now you take the fluid out and the lung expands. And you don't want the patient to pump this again. So you introduce power here. And what will power do here?
Oh.
So fluid can come out. Because the visceral pleura has stopped the greater pleura and put your lung that has really expanded into a case. So your lung is not squashed anymore. So you'll be able to breathe. Right? Yeah.
And that affects the whole entire lung, or just that specific area where the pleural
No,
injury?
if you in the hemithorax. Pleurodesis is usually the hemithorax of the effusion. Okay. Okay. So for the right side, you do the left side. The pleural spaces are not connected.
Right.
The effusion and the yeah.
Before the effusion though, their breathing will be different.
Of course, because the effusion collapses the lung.
That's what you're saying, right?
No, I would say because now you don't have, like, pleura, you can expand and recoil, right?
You can still expand and recoil. Only they don't do now. They don't do. There is no more space.
Okay.
So basically, what is happening is before the visceral pleura and the greater pleura have this spacing between them. It's a very microscopic space, and the two of them are stuck together like two pieces of glass kept together by a film of water, right? When you have the fusion, you separate them like this, right? Once you break the fusion, you bring them closer together. The lungs are re-expanded. When you now make them fuse, remember this is connected to this now, permanently. But they are not the one responsible for the movement. It is the connection of your parietal pleura to the chest wall that is responsible for the lung expansion. So the only difference is that they still move together, but only this time they are not held together by that film of water, but by fibrous tissue that you have created. So the purpose is that that space does not exist anymore. Here it was a potential space, right? Now here it is obliterated, it does not exist. That's why it's so helpful. Okay? Good. You know, I like when I get asked questions that are very pragmatic, because that means I'm able to let you see the picture and you want it to be clear. That is so good. You know, I really enjoy that. This is a very bad habit. I don't like leaving things on the board. I'm sorry. Okay, so treatment of pleural effusion. If it's a small effusion, it's symptomatic. Less than 1 centimeter thickness or lateral decubitus expansion, leave it alone. You will know what about it. You do a therapeutic photosynthesis for large effusion, regardless of the type. X-ray with pH less than 7.2 or glucose less than 60. So pay attention. The only two reasons you will tap an effusion as a treatment when it's large and symptomatic, whether it is candidate or exudate, it doesn't matter. If it is putting your patient in respiratory distress, you tap it. If it is an exudate, regardless of the amount, you tap it. If it is recurrent or it is associated with malignancy, you have to fuse the pleura. You fuse the pleura in the process called pleurodesis. What are the agents we use? Talc, tetracycline, doxycycline, bleomycin. And you would think that it will obliterate the space, but sometimes pleurodesis will fail. When pleurodesis fails, then you have to put an invalid pleural catheter, right? So you leave the catheter in there and the patient carries the bag. You dress
Just licks it.
completely. You know the way BPH patients carry catheter bags strapped to their legs? Only patients with breast cancer that have recurrent pleural effusion, when pleurodesis fails, they have to carry a bag, right? And it's a very, but not a good thing. But there is another option. You can shunt the fluid. You can put a catheter to shunt the fluid from the pleural space into the peritoneal space, and the peritoneum will reabsorb it. Okay? Or you just do surgical decortication. So you go there and you strip the pleura out. That's what decortication is. So the thoracic surgeon goes in and just strip the pleura of the lung. Generally speaking, they strip the visceral pleura. Okay. All right. So what are the complications of pleural effusion? Empyema. Empyema is when the effusion, because it's been there for a long time, the inflammatory cells linger for the longest, and the fluid is not converted into frank pus. When the fluid is converted into frank pus, it is called empyema. So empyema is pus, not fluid, pus, PUS, in the pleural space. Once you have pus in the pleural space, there are only three outcomes. It can stay in the exudative stage and get reabsorbed and goes away ultimately. It might take longer, but it will go away ultimately. Or it can start forming, the macrophages in there can start laying down fibrin. So the body is trying to fix it like it's a tissue. So you begin to lay down fibrin, then that is when it goes into fibrillopurulent stage. And then when that entire pus is converted into a solid fibrous tissue, you see, organized. That means that space is not reclaimable by any intervention except surgery. Okay. What you really want is to diagnose your patient before they get into this organizing stage. Because when you get them into this, when they are in the exudative stage, you can at least have it, you can have a bore needle, a big bore needle, or get a chest tube, wash it out. Right? Once they are organized, you forget that. So antibiotic therapy and a tap is what you really need. And the antibiotic therapy for empyema is at least 4 to 6 weeks. Pneumonia, 2 weeks. You treat most pneumonia 5 days actually. Bad pneumonia is max 2 weeks. Empyema, you're going to treat for 4 to 6 weeks. Okay? When that patient presents late and the empyema is in the organizing stage, that is what fibrothorax is. So fibrothorax is the fibrotic obliteration of the pleural cavity. Pathophysiology is untreated hemothorax, fibrosis and fusion of the pleural membranes, contraction of the hips lateral hemithorax, clinical presentation, a restrictive lung disease, treatment, surgical decortication. So let me make sure that you really understand what that is. Remember when Kara asked that question, like, are you not going to compromise the patient's respiratory capacity with pleurodesis? I said, no, you won't, because the parietal pleura is still attached to the chest wall, right? And it's attached to the visceral pleura, and the lungs can still expand. That is not going to happen if that effusion remained there and got organized there. The lungs cannot expand, therefore it will present like a restrictive lung disease. because the chest will not be able to expand. The lung can expand, the chest can expand. Okay?
Can you say that again for me?
The only reason the lung can expand is because the chest expands. When the chest expands, negative intrathoracic pressure, lung responds to that, they expand. For as long as the visceral and parietal pleura are attached together and attached to the chest wall, once the chest wall expands, it drags the pleura with it, and lungs expand as well. But if there was an effusion that separated the parietal and the visceral pleura and never got drained and got organized, so become a solid block of tissue, that means even if the chest expands, it can't expand because it's being held down, right? And secondly, the lungs cannot expand because the block of tissue is sitting there in the thorax, right? So clinically speaking, you will see that as a restrictive lung disease. When you do the flow volume look, you see like it's a restrictive lung disease. So if this has happened to somebody in Tanganyika, for instance, right, and then they survived it somehow, and then they now come with shortness of breath, you will see restrictive lung disease on flow volume loop. Then you do a chest x-ray, you will see what looks like an acute effusion, but even your physical examination will look like an effusion because fibrosis presents exactly like effusion, right? Everything about it is the same. The only difference, the way you know it, is that your patient is not sick. He only has this shortness of breath because it's not an acute illness. It's fibrosed now. It's chronic, but it's permanent, right? So that is why it will present like a restrictive lung disease. You got that?
I got it.
All right. Any more questions? No more questions? Huh? Yeah, you're due for a break now. 5 minutes. We're going to talk about pneumothorax. Pneumothorax just means air accumulation inside the pleural cavity, not excessive. There shouldn't be air. Air is not part of pleural cavity. There should be no air in your pleural space. Okay? I told you that the visceral pleura and the parietal pleura, they are stuck together like two slides, microscope slides that are stuck together like thin fluid. That is the normal. There is no space, no air at all. Okay, so air is not normal in the pleural space. So look, this is what you get when you have pneumothorax. You have air, and the visceral and the parietal pleura are separated all around the lung by that air in the space. That is what that is. Okay? Right. What causes pneumothorax? Many times, more often than not, pneumothorax is spontaneous. There are a few times it can be induced. And when it is induced, you can dismiss that. It's usually iatrogenic or chest wall trauma, stab wound to the chest. Or you punch somebody so hard, you fracture their rib, you puncture their lung, air leaks, right? But more often than not, well, in Westwood, it will be, if it is induced, it will be iatrogenic. In South Central, if it is induced, more likely chest wall trauma, right? So thoracentesis, pleural biopsy, lung biopsy, central line placement. You know central line placement? You can puncture the apex of the lungs that comes from the thorax, right? Remember what you guys, next in the summer you talk about subclavian and all that stuff. Yeah. Okay. So that is all I'm going to talk about induced, because more importantly, you will see it spontaneous. When it is spontaneous, it can be primary or secondary. A primary spontaneous pneumothorax is a pneumothorax that does not have an underlying lung disease. So the patient was not asthmatic, no TB, nothing. They just, boom, developed this pneumothorax. They are usually due to ruptured bleb and bullae. You know what those are. We talked about them already, right?
Yes.
Yeah. Secondary spontaneous pneumothorax means there is an underlying lung disease. So you have obstructive airway disease like bronchial asthma, emphysema, cystic fibrosis. So the patient has a history of a lung disease. Or it could be a restrictive lung disease, and you have to recall all those lists we talked about in restrictive lung disease when we talked about lung function tests, sarcoidosis, pneumoconiosis, tuberous sclerosis, lymphangiomyomatosis, idiopathic pulmonary fibrosis, Langerhans cell granulomacytosis, granulomatosis. Okay. All of those, they are all restrictive lung diseases, right? These are all causes of secondary spontaneous pneumothorax. Infectious lung diseases, look, necrotizing pneumonia. Under normal circumstances, not all pneumonias are necrotizing. A necrotizing means tissue breaking down, right? So, under normal circumstances, in pneumonia, the alveolar space fills in with pus, cells, and inflammatory exudate, right? And then as the pneumonia resolves, the exudate is cleared, and the alveolar space is left intact. But there are some pneumonias like Staph aureus that produce all these lytic enzymes that can actually break down alveolar walls. So that as you're having the pneumonia, you're also breaking down alveolar walls. So you're forming blebs. Once you lose alveolar wall, you begin to form air sacs, bullae. If it happens near the surface, where it's only the pleura separating that air cavity from the thorax, that is called a bleb, right? All you need is something to happen to that pleura, the visceral pleura, and that air space will open into the thorax and get pneumothorax. And that pleural space can be ruptured by a punch. You punch somebody in the chest in the right place, you can cause that to happen, right? So necrotizing pneumonia, pneumocystis pneumonia, TB, and then pleural endometriosis, that is called catamenia or pneumothorax. Did you know about endometriosis?
Yes.
Everybody knows about endometriosis? Okay, good. So endometriosis is when you have endometrial tissue that is not in the uterus. So people bleed in. When they're supposed to be having their period, they have their period and they have the monkey sex syndrome. Right? Everything, all day, if it's in the bladder, they get bacteria with their period. Right? That doesn't mean there's ectopic endometrial tissue somewhere. All right, okay. So, again, this is a difference between bullae and bleb. Very important that you understand that. All right. So when we talk about pneumothorax, it is important to differentiate between a simple pneumothorax and a tension pneumothorax. The classification of simple and tension pneumothorax is analogous to the differentiation of effusion into transudate and exudate. It has therapeutic significance. It matters in terms of what you do to treat the patient. So, a simple pneumothorax can be closed or open. Simple pneumothorax, simply means it's simple. It doesn't have any problems with it, right? Patient will be okay. It's simple pneumothorax. The pressure is okay. Within the air in the pleural space is not under pressure. That is really what it is. In terms of technically speaking, a simple pneumothorax is air within the thorax that is not under pressure. It's a simple thing. It could be closed or it could be open. See, if the air is coming only from the lungs and that space does not have any communication with the outside, that is a closed pneumothorax, right? But if it's coming from the outside because of the stab wound, that is an open pneumothorax. Tension means it's under pressure. tension can be open or closed. Because what really makes it tension is the air is now under pressure. How does the pressure come? Let's talk about that. So think about lung. This is lung. It is breached. The visceral pleura is breached. But the breach is in such a way that 2 layers have been put on. So when the patient inspires and air rushes into that lung, this flap is lifted and air comes into the pleural space. When the patient is in expiration and the lungs are recoiling, this flap comes down and traps the air inside the pleural space. The patient takes a deep breath, it opens again. You let the air in, and when the patient is breathing out, it closes. See how the tension comes? That simple flap will convert that simple pneumothorax into a tension pneumothorax. Why is that deadly? Because that means your thoracic pressure that is normally negative, even when you're in expiration, the pressure in your chest is never positive. It goes from less negative to more negative. The pressure in the chest is always on the negative scale. When you have tension pneumothorax, you have positive pressure in your chest. Think about that. That means your lung will be squashed. Right? Positive pressure will now squeeze the lung. That means your heart cannot, venous return cannot, blood cannot return to your heart because now the pressure is, normal mechanism for venous return is negative intrathoracic pressure that sucks blood up. When the pressure becomes positive, what happens? Venous blood cannot return. If venous blood cannot return, you can't have cardiac output. Patient goes into hypertension. The brain cannot empty. The superior vena cava cannot empty into the chest. Cerebral edema. The patient will be dead in minutes if you don't do something. Okay. So that is why it is so important to differentiate between a simple pneumothorax and tension pneumothorax. Okay? And it's, thank goodness, it is not that hard. Because not all pneumothorax is tension. Thank God. Many of them are actually asymptomatic, small, and simple. All you can say as a clinician is that the patient has a pneumothorax and is asymptomatic. Whether it is small or simple, these are actually, small is the radiographic parameter. You know, it's not like in a big way you say less than 500, right? When we call pneumothorax small, there is a specific radiographic criteria we'll talk about later on. When we call it simple, it means symptoms of, just patient present with symptoms of the cause of the pneumothorax. It's not under tension, basically, I can tell you. When a pneumothorax is symptomatic, they could be large or they could be tension. More often than not, they are large, they're tension. Okay? Tension pneumothorax is an unstable patient. You know in medicine, we say somebody's unstable when blood pressure is dropping or when they're losing consciousness acutely. Okay? Again, simple pneumothorax, they may be asymptomatic. Tension, they are going to have respiratory distress and they're going to have cardiovascular collapse. Especially cardiovascular collapse with tension pneumothorax. And it's easy to tell. The guy is short of breath. You examine him. His trachea is deviated to one side. Usually, if it is pneumothorax, that's because the effusion, the pneumothorax, the air is pushing the mediastinum to the other side. So trachea is deviated to this side. The apex is now towards the midline, rather than being in the fifth intercostal space over here, right? So you have this mediastinal sheath. The chest movement is rigid. Chest is not moving because it's under pressure. It can't expand. It's not positive pressure. Percussion notes, they are hyperresonant because it's air. There is no breath sound because the lungs are not expanding. Air is not moving into the space through the lungs. Diaphragmatic is absent. And when you percuss, it's hyperresonant. Okay? So these are very easy to see. So that's why you look at somebody that is short of breath. If there's a guy, you just look at the Saddam sample. If the Saddam sample is going down and going this way, that means his trachea is shifted. Right there and then. Women, you have to kind of take a little closer look. Alright? So that is why I tell you that simple attention, they're not child's play. You have to be able to make that decision in seconds. I mean, literally 10 seconds. Okay, Bina, I'll get in it.
You wouldn't see a JVD associated with it?
You will see JVD, but if you take a little longer to diagnose it, yeah, JVD will come, right? You might even have, you'll see JVD. You will have Kussmaul signs and all those other stuff. We'll talk about that next week for my cardiac lecture. Yeah, because if your superior vena cava is not able to empty, the jugular venous will be distended, right? So you will see that. Good point. Yeah,
Is potential pneumothorax worse in one side of the lung versus the other side of the lung?
Not really.
Yeah, but I'm just wondering, like, the pressure, is it worse for your heart being squishing towards the left side, or is it worse to have?
That is a very good question. Technically speaking, cardiovascular collapse will happen sooner. Or should happen sooner on the left than on the right. Right? Because on the left, you're going to be actually displacing the heart and bending things out or creating kinks in the superior and inferior vena cava, right? And that can actually make the cardiovascular collapse come on more. So technically speaking, you might have earlier cardiovascular collapse on the left than on the right. But do I know that? Has that really been proven? No. But looking at just simple anatomy and how the body should work, it might be. But I've not really heard about that or seen that before. Not that I've seen it, thought about it. Nobody has said, And I think that's something I'd like to check in. If it's not been done, that's a paper right there. Right? If you like, I can walk with you on this. Just look at cardiovascular collapse and pneumothorax, one side. And it's easy to do. Hospital discharge database, we have it. Just look at the diagnostic code for pneumothorax. And you look at the presentation of the patient. Right and left. You should do that. You really should. All right, so what happened? How did I get here? Okay. All right, so you might have told you that whether it's small or large is X-ray. See how pneumothorax looks? Do you see the very subtle difference between pneumothorax and normal lungs? The only difference is that in pneumothorax, you get air and you don't get the pulmonary lung markers. Those clean white lines are not there because it's air. Okay? And you can see how a pneumothorax will collapse the lung, will push it close because it's negative pressure. Yes, a positive pressure. Negative pressure will bound to positive pressure any day. You'll collapse it, you'll displace it. All of those things is what you now see when you examine the patient. Tracheal deviation, reduced lung movement, chest wall movement, apex is shifted, absent breath, hyperresonant percussion sound, and all that stuff. That's why you see all this. Now, yeah.
I know it says on the So does that mean you only see those manifestations just with retention?
Say it again.
Do you only see those manifestations just with tension in the thorax? I mean, I know it says that, but is that true? Right? Like it says when your spinal shape.
Yeah. When it is large enough.
And that's only potential.
Yeah, only potential, yeah. Remember, simple pneumothorax is not under pressure, so nothing is shifted, nothing is displaced. The only reason everything is shifted and displaced in tension is because there is pressure, right? So pressure will shift things, generally, right? Remember I told you that small pneumothorax is not a clinical decision, it's a radiographic decision, and different colleges use different criteria. American College of Chest Physicians, they say if the apex to cupola distance is less than 3 centimeters, the effusion is small. I mean, the pneumothorax is small. If it's more than 3 centimeters, the effusion should be called large. The cupola is on the X-ray, the upper border of the remaining lungs, and the inner and the roof of the distance between the pleura, basically, usually and perineal pleura, right? That distance there is the apex cupula. If that distance is more than 3 centimeters, call it large. If it's less than 3 centimeters, it's small. The British Thoracic Society, that I tend to align myself with more, because they get more accurate on most issues. They say you look at the long chest wall at the high level. So you look at the higher level, at the level of the heart, and you compare the distance, chest wall, like that. Let me ask you, which one is easier to do on a chest X-ray? Is it the apex to cupula or chest wall? Is it A or B? Which one are you able to find easy to do? B, right? No, seriously, B is. Because on many chest X-ray, sometimes the apex is not even clear, right? So that's why I align myself more with it. And Professor Light actually came up with another index. This is not popular. His index for effusion is way more popular than that. So Light says, you know what? We can actually compare the volume of the collapsed lung to the volume of the thorax. So we know how much air is there, really. And he gave this formula, lung volume. So the top one is the volume of the lung, because it's cubed, and the lower one is the volume of the hemithorax, and -1 just means that's what is the proportion of the lung that is lost. The lung should be 100% in the thorax. And then he says if you can show that the volume of the lung is less than 15%, that is small, more than 15%, that is large. Okay, the air, the volume of the air. Okay, and this is one example of that calculation. I'm never going to ask you to calculate that. Okay, just know 15% and 3%. And sorry, 15%, 3 centimeters and 2 centimeters. Pay attention. Apex to cupula is 3 centimeters cut-off point. Long chest wall at the highlight is 2 centimeters. Don't get confused, they're not big. And then Light criteria is 15%. All right, so when you see air in the lung, what else do you see? Look at this. That is an air space inside the lung, right? It looks like a bullae. But the reason you will not call it a bullae is because it is surrounded by a thick tissue. There's a tissue line around it. That tissue line around it is what makes it not be a bullae. That is what makes it a nematocyst. Okay. Air-filled cavity within the lung parenchyma. They can be single or multiple. When do you find them? Necrotizing pneumonia, patients on mechanical ventilation, usually as a result of barotraumas, because the airway ruptures. Most of the time they are asymptomatic. Okay. Nematocysts occur deep on the chest X-ray as small, round, air-filled spaces inside the lung tissue and usually do not rupture, and they don't require specific treatment. So, anatomically, nematocysts have tissue around them, so they don't cause pneumothorax. But bullae are empty air spaces with very thin or no tissue around them, so they could rupture. So one big difference between bullae and nematocysts is that bullae could give you pneumothorax, and nematocysts less likely to do so. Okay? So how do you treat pneumothorax? We'll start with this one. Primary, spontaneous pneumothorax. Pay attention to those three criteria. It's primary, it's spontaneous, and your patient is dyspneic. You have to aspirate. Pneumothorax, your patient is not symptomatic, you can watch and wait. Primary, spontaneous. Symptomatic, you have to treat. Asymptomatic, you can watch and wait. Primary, keyword, primary. No underlying lung disease. Okay? You can watch and wait. Asymptomatic. If your patient is symptomatic, you have to do a simple aspiration or a small bore chest tube. Okay? If the aspiration resolves the problem and your patient is no longer symptomatic, you send them home. They're home and dry. If the needle aspiration does not work, then you do chest tube. Chest tube resolves the issue and there is no air leak, you're home. Chest tube does not resolve your issue, you admit the patient. It resolves, you remove the chest tube and you discharge the patient. It does not resolve, you call the surgeon. They have to do fix the leak. Okay? This is needle aspiration. 18 gauge. Just stick it in the chest and you aspirate and the air will come and lung will re-expand. Many people are so afraid to stick needle in the chest, and I don't know why. Because this could be life-saving. If you percuss and the chest wall is hyperresonant, you know it's air there. And you know it's under tension. If it is not under tension, the patient will not be symptomatic. Right? The fact that your patient is symptomatic means it's large and it's under tension. Why are you afraid? There is nothing in your way. The air already pushed them all out. Just take the damn needle in there. And your patient, you don't even need a syringe. Sometimes you just slam the needle and you could feel it sometimes. You eat in the face. Needle aspiration is as safe and effective as chest tube placement, provided and with shorter length of stay and fewer complications. It's safer. This is one of the few times when you as a clinician can do something and get the same result as a surgeon. Cost the system a lot less. Why are we comfortable leaving people alone when they're not symptomatic? If it doesn't bother them, you can't problem fix it. But why do we really do that? This is why we do it. Pneumothorax reabsorbs at a rate of 1.25 to 2.2% per day for up to 6 weeks. So if you leave the pneumothorax alone, if it's not under tension, right? You leave it alone. It's not a tension pneumothorax. It will reabsorb 1 to 2% a day. And it will keep reabsorbing for up to 6 weeks. So it has an inbuilt predisposition to spontaneous resolution. It will reabsorb in enough time at the rate of 1 to 2%. Okay? So think about it. If the effusion is 20%, it's a large effusion according to light, right? That's a large effusion. You just leave it alone. 1 to 2%, in 10 years, you'll be done. You won't see it again. Right? So that is why you don't, because you know why you shouldn't do it if it's not symptomatic and it is not tension. Don't stick a needle in there. Because that means there are no displacements. It's a small effusion, maybe from apical pneumonia. You stuck a needle now into the chest and you puncture the lung because nothing is displaced, everything is still intact. You stick your needle, then you puncture the lung and drop. Right? Because now your patient has double pneumothorax. One is iatrogenic, the other one is spontaneous. Right? And that is not a good thing.
Dr. Martin,
yeah.
And these are the same like rules that you had for the pleural effusion. If it's simple, you wouldn't necessarily have to do
pleural effusion.
Yeah, from back here, right? Because you were saying that like if it was like a smaller amount of fluid that was in there, and the patient was asymptomatic.
Are we talking? Is your question on pneumothorax or pleural effusion?
No, I'm just comparing them right now.
Okay.
So I'm just wondering like for like this one right here, you just said like if it's simple and they're asymptomatic, you wouldn't have to actually
leave it alone. Yes.
Yeah, you leave it alone. And the same thing for the simple pleural, right?
Well, in pleural effusion, we generally don't talk about it in terms of simple because there is no tension pleural effusion.
Oh,
we're talking for pleural effusion, it's either transudate or exudate, small or large.
Yeah.
Right?
Yeah.
For pneumothorax, you talk in terms of simple or tension.
Yeah. So in terms of it being small, would it also have this feature right here where it reabsorbs?
Yeah. In fact, if it is small or large, it does not matter. Small is, if it is like, what, 10%, it will be done in 5 days.
Oh, okay.
Right. So the size just tells you how long it will take to reabsorb. All I'm saying to you is don't stick a needle in anybody's chest, no matter what anybody else tells you. Don't stick a needle in anybody's chest that is not symptomatic. You're more likely to cause problems. Okay. So remember, this is the approach to primary spontaneous. Primary spontaneous. Look at your approach to secondary spontaneous. Supplemental oxygen and or drainage like chest tube or small bore catheter. Hospitalization. There is no room for watching and waiting secondary pneumothorax. You don't watch and wait secondary pneumothorax. It's a big deal. It's a problem. You know why you don't? Because you don't know when that simple secondary pneumothorax can change into tension pneumothorax. It could happen like that. It could happen in your parking lot as a clinician. So there is no room for watching and waiting for a secondary spontaneous. Where there is underlying lung disease, you don't watch and wait. You got that? Mm-hmm. That was why I kept saying primary. Extremely important that you understand the difference. Okay? So lung expands, oh good. With not an air leaks, that is fine, you're fine. If it keeps coming back, lung expansion and you can't get air leaks to stop, you do surgical pleurodesis. You do exactly the same thing we do for pleural effusion. And if you can't do surgery, you do chemical pleurodesis. Okay? Why do you think we give supplemental oxygen? Why do we give Mary, why do we give supplemental oxygen to pneumothorax? Well, think about it. Why would we give supplemental oxygen to somebody with a large pneumothorax? Simple pneumothorax. Why would oxygen do anything? Okay, so think about it. Pneumothorax is air. Air is 70% nitrogen. So if you give them 100% oxygen, you can dilute out the pneumothorax. It will resolve faster because the nitrogen, you will dilute out the nitrogen, which is 70% of pneumothorax. Okay, that's why you give 100% oxygen. So simple secondary pneumothorax. Okay. Now, video-assisted thoracoscopic surgery with or without fluorisis is indicated in all cases of secondary spontaneous pneumothorax because they tend to be recurrent and are unlikely to resolve spontaneously without intervention. That is why you have no room. Not only they are recurrent and they don't generally resolve, they can also progress from a simple to a tension. So if a COPD patient in your clinic and you do x-ray and you see pneumothorax in a COPD patient, you send him in because that conversion from simple to tension can happen anytime. A cough, a sneeze, many things can trigger it. You don't want to be the one to make the decision to watch and wait. No. Let somebody else make that decision. Okay? Those things. Again, this is a reminder that the smaller the number, the larger the needle. And it's from Birmingham. The British did that. Okay, so how do we treat pneumothorax? Pulmonary collapse, typically 3 to 7 days. Well, I'm talking about treatment of pneumothorax. Let me not go to complication. Treatment of pneumothorax, get rid of the air. Stick in the needle, put in chest tube, do whatever you have to do. Give oxygen. If it's a simple pneumothorax, large, you give 100% oxygen, you might be able to wash it out. Right? If it's a tension pneumothorax, stick in the needle, put a chest tube, do whatever you have to do, get rid of the air. That is the treatment. It recurs, use the pleura. Okay? You must show that the air went away and the lungs re-expanded. Okay? Very important. Now, there is something called re-expansion pulmonary edema. So typically, when there is tension, usually associated with tension in the thorax, I hope you realize that re-expansion really is needed only for tension in the thorax. It's tension in the thorax that will collapse your lung. If it was a simple pneumothorax, re-expansion is not going to happen because it will never collapse. Right? I want to make sure you got that. But see what happens. When you have pulmonary collapse that has been on for 3 to 7 days, this is what happens. You decrease surfactant. Okay? Because surfactant production is related to lung expansion and recall. The lungs that is collapsed does not get blood. Right? So you get hypoxic. Hypoxia is one of the causes of inflammation. Right? So not only are you getting mechanical alveolar injury, you are interfering with the alveolar capillary barrier and the membrane. Right? You're getting polymorphonuclear cells responding to that inflammation. They're going to come and start reducing all these chemokines, all these inflammatory chemicals. You have injury to the capillary wall with increased capillary permeability. And all of a sudden, you stick in your needle and you really expanded that lung. And all of those chemicals and that inflammation, because of the expansion and increased blood flow, boom, you get pulmonary edema. It's called re-expansion pulmonary edema. It's a complication of treating pneumothorax. How can you prevent this? What precaution can you take to prevent people from getting re-expansion pulmonary edema? Anybody want to guess? Go slow. Start slow. Use small catheter. Use smaller needle. Okay? That way, the increase in blood flow is gradual. The expansion is gradual. And you can minimize. You cannot altogether eliminate it, but you can at least reduce the risk of re-expansion pulmonary edema. Okay? Our job as healthcare providers is delicate. Every single day of your life, you will balance life and death in the lives of people. Balance life and death. Balance life and death. Especially if you work in the PPA hospital. You know the best exciting environment to work in medicine is the ICU. ICUs are fun places. ICU is where you can, ICU validates you. When I was in the ICU, they bring people from the floor, right? And they're dying or they just recovered from death. And we just get them all connected and wired. And you're looking at numbers. And based on numbers, you're making changes. And within minutes and hours, you're getting results. A guy that is torn down will start moving. And one day he will open his eyes and he will look at you like, of course you're wearing a white coat, he knows you're a doctor. Then say, hi. I mean, it's an amazing place to be. Honestly, it's better than the emergency room. It's better than the blue side or the red side. The red side is too bloody. I hated it. But if you really want to kind of see how much simple things you know can make differences in people's lives, whether they live or die. Be in the ICU, whether CCU or MICU or SICU, does not matter. Just be in the intensive care unit. Because it's a rapid-paced environment. That is where you know how quickly you can think as a clinician, and people can see it. Nurses are watching you. Everybody is watching. And it's just fun place. Oh my goodness, one of the greatest times I had across the street was those days I used to do ICU rounds. And the only reason that makes it exciting is because it's so fast-paced. People die quickly and they leave quickly. You know what I mean? There are people you will come and they will do everything. Liver fed. Whatever drip there is, you give it and say, it's coding. I'm like, the guy coded 3 times. Why do I keep bringing it back? He's going to end up brain dead. Anyway, let's go. When you get pneumothorax, you have a big problem. You really cannot do any heavy lifting for at least 2 weeks. So if you work in construction, you need to be up for at least 2 weeks. You cannot do scuba diving after pneumothorax unless you went through pleurodesis, or else you will recover, especially if it was spontaneous the first time. Scuba diving can make it come again. And you cannot travel in the air for at least a week after the resolution because of the pressure changes. Okay? So let's talk about pleural implant. Okay, before I go, any questions on pneumothorax? So it's very simple. Pneumothorax, all you want to know is it primary, secondary? Is it simple or tension? Open or closed, just for whatever it is. Because open or closed does not mean really much. If it's open, you need chest wall surgeons to come treat you with chest wall. If it's closed, you can manage it. That is the whole point of open and closed, whether it's surgical or medical pneumothorax. What is really important in terms of treatment, is it simple or is it tension? And you know how to differentiate between small versus large using epicopular chest wall diameter or light trajectory. Okay. It's very simple and straight. Sticking the needle, be careful. Use small needle so you prevent re-expansion when you right? So let's talk about pleural neoplasm, the last one. Well, neoplastic diseases of the pleura, they could be primary or they could be secondary. It is so strange in the pleura. The pleura is one of the places where secondary tumors are more common than primary tumors. Okay? It is also the place where malignant primary is more common than a benign primary. Okay? That is not normal. Okay? So, you can have primary or secondary tumors. Primary could be benign or malignant. Secondary means they came from somewhere else. In the pleura, secondary tumors are the most common tumors. Malignant, among the primary category, malignant are more common than that. Okay, and the commonest of malignant primary tumors of the pleura is mesothelioma. It's the most common, associated with exposure to asbestos, 80% of it. Okay? Most common source of secondary to the pleura is the lung. Bronchogenic cancer is the commonest source of pleural secondaries. Okay? So once you think about it, initial evaluation is usually by CT scan or chest X-ray. And for evaluation, you might need MRI or PET scan, but once it's secondary, you know, because the primary cause of it is obvious, lung cancer. Spreading to the pleura, that is no news. Mesothelioma, you've heard a lot about it. You know? So this is just, I don't know where I got this from, but it's a good cartoon. It gives you a summary of everything. Mesothelioma, or more precisely malignant mesothelioma, is a rare, even the name is very strange. Because generally in medicine, when we call something oma, it means it's benign. Like oma, sarcoma, sarcoma, right? Generally when we say oma, it's benign. When you say sarcoma, it's malignant, right? But mesothelioma is actually malignant, right? It's an anomaly. It's a rare form of cancer that develops from cells of the mesothelium. Every organ inside your body carries with it from your embryology stage a mesothelium. Because remember, we're all structures of tubes. We're all worms. Yeah, all of us. We're these single worms, and from that inner layer of that single worm, you get invagination, diaphragm, heart invaginated, and that's how we now form these organs within. And because we're once these tubular structures, we carry with us that mesothelium. So mesothelioma is not just always in the pleura. It could be any organ that formed by invagination carries the mesothelium can get mesothelioma. That is why, although it is most common in the lungs and in the pleura, you can find it in the testes. You can find mesothelioma in the peritoneum. You can find mesothelioma in the pericardium, right? So mesothelioma is not necessarily a pleural tumor, but it's the most common pleural tumor. Okay? How do they present? It depends on where they are. Shortness of breath, cough, if it's in the pleura. Arrhythmia, chest pain, difficulty breathing in the pericardium. Testicular mass, which is in the testes. Whatever where they are. In the pleura, they present like a pleural tumor. It's like you would think, dry cough, shortness of breath, and stuff like that. There may be a fusion. And some layers, because it has a very strong association with asbestos, some lawyers like to make a big deal out of it. And those companies don't care about it because treatment often involves surgery, chemotherapy, and radiation. We have treatment, but see, only about 8% of patients survive for more than 5 years. So you can start the case, but the patient will be dead before the case is resolved. So what the companies do is to drag the case forever. So not show off, call for extension. So they're doing what they call that thing, fact finding, but they call it discovery. So they're in discovery. Ask the judge to extend because they're hoping that by 5 years, Once a client is dead, case is over. Good. Any questions on this? It's very simple. You just have to know that it's not just a pleural tumor. It can be found in so many places, pericardium, testicles, peritoneum. It's chemosensitive, very sensitive. Sometimes you have to do surgery. It depends on how the patient is presenting. Very high number. And he has a very strong association with asbestos. All right, so let's go now and do some fun. So which of the following, Stephanie, which of the following is not a common clinical manifestation of pleurisy? Pleural splenosis.
What's that?
What is pleural splenosis? Yeah, you're going to tell me about that. It's spleen tissue. It's when you have spleen tissue that has escaped through the diaphragm and they seed on the pleural. Okay. Pleural splenosis is not one. All right. What is the estimated volume of pleural fluid in a 70 kg man? 14. Good. That's 0.2, right? Good. Good. So it's 14, right? Y'all agree with me? Mm-hmm. Oh, you agree with her? Sally. 76-year-old male, hypertensive diabetic patient with a history of chronic kidney disease. That patient is really sick. Okay? Mm-hmm. 76 is old. Good. He comes in with shortness of breath for 3 days. Dry cough for 1 week. But he said abdominal swelling has been going on for 2 weeks. His legs have been swollen for 4 weeks. He denies autopnea and fever. So let's take a look at that history. His problems started in his legs. Yeah. 4 weeks ago, right? Mm-hmm. And the edema went up. Right from that chronology, what conclusion can you make?
It's a pleural related, like a pleural effusion is about to come through.
What are you talking about? What system can you implicate from that?
Oh, lymphatics. Is he pitting or not?
I don't know. I'll tell you that later. But I want you to just calm down and look at that. What I want you to tell me is, based on that thing right there, is this person having a cardiovascular problem, a liver problem, or a lung problem? Leg swelling first, then abdominal swelling. Now he has shortness of breath, and he had this dry cough.
It's cardiovascular.
Exactly. Yeah. So this person's problem is a circulation. Something is wrong with his circulation.
So it's a hydrostatic
and whatever is wrong with his circulation is more on the right side. Okay. Because he does not have autopnea. Autopnea is when you have to sleep with many pillows because you can't breathe. If you sleep with many pillows because your food is coming out in GERD, that is not correct problem. Yeah. So the fact that the patient does not have autopnea tells you that, well, something is wrong with his circulation, and it looks like there's a problem more on that right side. The problem is more on the right side. Right? Because when your right heart fails, the first thing that happens is your legs swell, your abdomen swell, your liver swells, becomes painful. Then you don't fix it, your neck pains. But that is how you synthesize clinical cases. You must know how to do this. So it's not an area. When you examine the patient is in mild, moderate respiratory distress. So the guy is really short of breath. His blood pressure is 150/90. He's hypertensive, we know that. His pulse is 102. Probably hypoxic, right? Mm-hmm. His breathing 18. I told you it could be tachycardic because of hypoxia. Yeah. Will you be breathing 18? Okay.
No, because if you
So
do
you
it
see,
faster,
that
choking the
tells you
oxygen.
that this guy's presentation is a little bit confusing, right? There could be something wrong with his lungs, right? But it's not coming from his heart, right? Are you following me?
Yeah.
Excellent. Temperature is 98, so it doesn't have pneumonia, right? And it's not the type bacterial pneumonia and stuff like that, right? You're examining his chest. The only significant findings is in both lung bases. He has absent breath sounds, stony dull percussion notes, tactile and vocal premises absent, even without going over here. Stanley, what is the most likely diagnosis in this patient?
I would see pleural effusion.
Good. He has pleural effusion. Any dissent? Anybody disagree with anything?
I mean, like, we did.
I'm asking if anybody disagrees with you.
Oh, okay.
Yeah.
I don't think so.
Okay.
What would make you pick B instead of the?
What will make you pick B?
No, the C instead of the B, because in the beginning.
C instead of the B?
Like, they're both explaining both of the different.
Well, the reason that you will not pick congestive heart failure is really because the guy is not happening. It's not autopnea. Autopnea is a major cardiovascular system symptom. Autopnea, PND, paroxysmal national dyspnea. Those two, they are almost always heart failure. Okay? It cannot be pneumonia because the guy is not febrile. Right? So, Stanley, well done, man. But now let's now see. Urinalysis, he says he has proteinuria, glycosuria, he has material. Well, he's entitled to all that based on his age, his diabetes, and everything.
Yeah, chronic kidney disease.
CBC is within normal limits. That means he can't be pneumonia, really, right? And EKG, he has left ventricular hypertrophy with sinus tachycardia. Yeah, so what? The guy has effusion, he has volume depletion. It might be the matters, but intravascular volume is low. Right? You can have high volume and be depleted at the same time. Right? If your fluid is not within your vascular space, that's where you need it. Yeah.
So is the leg swelling and abdominal swelling just due to the fact that the venous return isn't as efficient as it usually is, so now it's just backing up?
That is correct. That is correct. So,
yeah.
His leg swelling. Does he have pedal edema? Does he have pedal edema? So if the patient tells you they have leg swelling, but you can't see it, should you think about it in your assessment? That means his leg swelling has nothing to do with what is going on right now.
Wait, you said if there's no pedal edema.
If your patient tells you, my leg has been swelling for 4 weeks, but you examine the legs, you can't see pedal edema. Right? You know what I mean? So that just simply tell you that that leg swelling has nothing to do with what is going on right now. Are you understanding what I'm saying? It is the way life is. So when you read questions, from the symptom, right there and then, you should anticipate what you're going to find on the physical examination. So if your patient comes with leg swelling in an exam question, and they don't tell you there's pedal edema, that is a distraction. It's something they put in there to make you go off on a tangent. Right? But good. Nobody can take you off that kind of tangent. All right, so let's see this. David, which of the following criteria is diagnostic of an exudative pleural fluid? B, good. I mean, it's above in both cases, right? And it's fluid first. 0.5 for protein and 0.6 for LDH. Right? Don't forget that. Really?
You said it's above.
That's great.
Oh, you said B. I don't know why I think it's.
B as in Baba.
I was thinking C.
Ali.
Can I move on now?
Yeah, sorry.
All right, so, Vinny, what is the predominant cell type in a normal pleural fluid?
Mesothelial. You got shot, man. You got shame shot.
That was a laser.
Mesothelial.
It's mesothelial cells, 60%. You forgot? It's mesothelial cells. Ali, 67-year-old female hypertensive smoker with a history of congestive heart failure. Ran out of meds 6 weeks ago. She comes in with productive cough 3 days, progressive shortness of breath for 1 week, 4-pillow orthopnea for 1 week, bilateral leg swelling, 2 weeks. Index review of system is positive for indigestion and nocturia. What is nocturia? Day overnight frequency 2 to 4. Why do people get nocturia like this? Why will this kind of patient get nocturia? Most cardiac patients get nocturia, especially when they have edema, because when you lay down, gravity increases venous return, and cardiac output increases. So you wake up more at night to pee, because cardiac output increases, renal blood flow increases. But when you're upright, you hold fluid in your legs and dependent areas. So the overnight frequency is supposed to be 4/2 or 4/0 to 1 actually. But it's flipped in this patient, right? She's in respiratory distress, blood pressure 160/110, pulse rate is 120, she's breathing at 28. So you know she has lung problem, right? And that lung problem is probably connected to her heart, right? Because she has all those florid cardiovascular signs and symptoms, right? Absent breath sounds at both lung bases. Dull percussion note at both lung bases, but greater on the right. Much more greater on the right. Absent and tactile and vocal firmitus. Bilateral pitching pedal edema in this case. Okay, it's not written, but I want you to insert it there. It's there. Right? And Ali, you're listening to me, right?
Yeah.
Okay. O2 sat is 90 on 5 liters. This is the blood gas. This is the chest x-ray. It's a very simple question. What is the next best treatment option? In order for you to answer that question, you have to tell me what is going on first.
Well, she's swollen, so there's a lot of edema due to her heart.
Okay, and then why does he have dullness to percussion note? Is dullness to percussion note a sign of pulmonary edema?
Yes, but her heart's causing it.
No. Dullness to percussion note, stony dullness, I should put stony dullness there, to percussion note is not a sign of pulmonary edema. It's a sign of, dullness is a sign of pulmonary edema or consolidation, right? So this dullness to percussion, and especially when it's more on the right than on the left, that tells you there is something, there is pleural effusion, it's more on the right than on the left, right? Okay, and absent tactile and vocal firmitus, that's not normal for pulmonary edema, right? In consolidation, which will mimic pulmonary edema, these things are supposed to be increased actually, right? Exactly, but they are absent here. I mean, they are so low and not perceptible, right? So, what do you think is going on? You think it's a heart problem, it's a pleural effusion,
But if there's no pulmonary edema, then why would you use, because I was thinking blood pressure control and aggressive diarrhea.
Why did you say there is no pulmonary edema?
You were saying that the dullness to percussion.
Oh no. I'm trying to get you to see that the chest findings are not crisp. There is overlap of pulmonary edema and something else, right? Because just from the history alone, you know this patient has pulmonary edema, right? You know that. Because the reason she has a dyspnea, and I could put PND there as well, is because the lungs are filled with fluid. So pulmonary edema is there from the history, right? All the pulmonary symptoms of heart failure are usually due to pulmonary edema, okay? But the chest signs are not, the breath sounds are absent at the lung basis. Yeah, you can find that in pulmonary edema, right? Or dullness to percussion note and absent tactile fremitus? No, you don't. Tactile fremitus and vocal fremitus actually increase in edema, like they are in pneumonia, in all consolidation, right? So the fact that they are absent here means that this patient has a lot more than pulmonary edema going on. And it is not uniform, it was on the right side. And then I'm showing you the x-ray. What do you see on the x-ray?
Missing the X.
Okay, the cosmeric angle is blotted on the right, and there is pulmonary edema. The lung is whiter than it should be, right? And of course, from this, you know she's hypoxic. So now you know that this patient is in heart failure, and there is some transudate. You can figure out what is going on here, right? Now, how would you treat this person?
I honestly would probably do all of the above.
You would tap this one?
Well,
First of all, the question is next best.
so maybe get her blood pressure under control.
Thank you.
And
This is a
then,
paraneumonic effusion. She has pulmonary edema. Sorry, not paraneumonic. She has pulmonary edema. It's an effusion, but it's a transudate because of the heart failure, right? Right? So if it's a transudate because of the heart failure, you don't go after the transudate. You go after the cause of it. Remember? Exactly. So you have to do two things here. You have to first of all identify that, well, this patient has CHF and possible pleural effusion. And if you can identify that here, since you know CHF and you see effusion, you can only call it transudate. That is not the one you want to tap. Why would you tap a transudate? Why would you tap, do a therapeutic thoracosynthesis for a transudate? And moreover, you say therapeutic. Would you really cure this patient's shortness of breath by a tap? If it was a diagnostic, it would be more difficult to tell apart. But in this case, it's a transudate. You don't need to tap a transudate. I mean, even though you don't have any criteria to say transudate or exudate, you have enough clinical information and the chest x-ray to tell you, well, there is pulmonary edema here. I don't need to be tapping this patient. I'm not going to cure this patient's shortness of breath because of this small effusion. Will this small effusion cause artificial of breath? Exactly. So you do aggressive blood pressure control. Okay. Bronchodilator and chest physiotherapy. Seriously. Cough for 3 days. But apnea for 1 week. Leg swelling for 2 weeks. You think bronchodilator? Did you hear wheezes on his chest? Why would you give him bronchodilator? Right. If he has wheezes and high pitch bronchi, and then you so yeah, he will benefit from bronchodilator. You think? Why would you give him that? That's the idea. So your answer is really aggressive, blood pressure control and diuresis. Okay, and they recover so fast you won't believe. You will not believe. These patients turn around usually in 4 to 6 hours. That is why they go to the emergency room. Because once they show up in the emergency room doctors, boom, Lasix. And they give them the bag or a urinal. She like 2 dozen times. And all the fluid is gone. They start breathing, then they go home. 2 weeks later, they come right back. Right? Is this a very difficult case?
There's just a lot to go back. You have to think. We don't
Yes.
think as fast as you guys.
That is the point. You have to think.
Yeah.
You have to think of what you know. And it's critical thinking. It's paying attention to information and being ahead of yourself by a couple of steps. Somebody give you symptoms, immediately you anticipate the signs. So you're going down. That's why Lindsay told you in the exam, read the answers first. That way you're able to contextualize the information you're getting.
She's the opposite.
She said the opposite.
Yeah, they said to read the question.
They said to read it last.
Lindsay told you that?
Come up with your own answer before you look at the
They said read the question, like what do they want?
Read the question.
Yeah.
That's what I'm saying.
Yeah.
Read the question. That's what I'm saying. Read the
Yeah.
question. Oh, I said read the answer. Sorry. Read the question.
Yeah.
Read this question, not this question. Read this question first before you read the story. Right? This is what I meant. Read the question first, and then helps you put this in context. You know. But generally speaking, I'm hoping that when I get my TA, because one of my plans is to get a TA here, so you guys can do this type of things every Friday. Depending on what classes you're taking, you will do this. Because you know the truth is, once you do that, you get into this the rhythm of clinical reasoning. You can identify tricks right off the back. As soon as they show you, you know it. Once I take the first step, you know exactly where I'm going. Until you can do that, you're not clinicians. You have to be able to listen to stories, anticipate your findings. By the time you're ordering the chest X-ray, you're not looking for what is there. You're looking for what you know should be there. And you worry when it's not there. See, it's not always about diagnosing things. It's also what is not present that should be present. You know? No, don't worry. You will do a lot of this. Definitely, you will do a lot of this. Your predecessors may not, because I don't know when the team will get. But you will do a lot of this. And for you guys, I want 100% pass rate. All of you.
When will we do this?
Right?
When will we do this?
Why will we do
When?
Oh, when? Oh. Definitely.
When we get started.
Well, honestly, truthfully, if you, I wish I could do it now. It's just that I need to, it's a lot of work. Because you have to go through the question bank, pick out the questions that address the topics you're currently treating across the board, and then do it with somebody that can explain why the answers are the way they are. It's supposed to be fun.
Yeah.
If I have anybody do it now, it's not going to be fun. I will not be able, if I have a faculty do it, it's not going to be fun. It will be so boring and routine. I want the questions set in such a way that it's exciting. And I don't have the time to do it now. But I promise you, you will do it. Latest in the fall. I'm working on it. All right?
All right.
Okay. Huh? All right. Which of the following pressure changes is associated with the formation of transudative pleural effusion? Annette.
This one would be increased hydrostatic pressure.
Increased hydrostatic pressure. Good. You got it. All right. Bradley. What is the minimum volume of pleural fluid required to produce a detectable blunting of the costophrenic angle on the frontal view of the chest X-ray?
Baba, read the Baba.
So let's match this special test to the appropriate options over here. Right.
High amylase would be to pancreatitis. High lipid would be to pylorus. High hematocrit would be hematothorax. Hemothorax. High NT-proBNP would be to heart failure. And ADA would be TB.
Good. Excellent. Any questions?
No.
It's an enzyme, anti-deaminase, yada yada yada. It's in the table, that table over there. All right. Justin, what is the best course of treatment in a 48-year-old male asthmatic smoker? with an asymptomatic pneumothorax on a chest X-ray obtained in the ER following blunt trauma to the chest. So it's asymptomatic, it's a pneumothorax, but the guy is asthmatic. And this was induced by trauma. What would you do? He's already in the emergency room. From the emergency room, you can send him home, or you can send him up. Most emergency rooms are on the ground floor.
I mean, it's asymptomatic, so.
And there's a history of smoking.
Good.
I want to be
B, yeah, you have to. This is a secondary pneumothorax. There is no room for watching and waiting. This is the one that could flip from you from simple to tension. So you will hospitalize this guy.
So if he wasn't asthmatic, then you could have sent him.
If this guy was a, wait, there's a question I have. Yeah. Okay, but this guy you will admit because this is secondary spontaneous, right? He's asthmatic, and he has lung tremor. Oh no, you will admit this guy. Then, which of the following conditions is an indication for pleuritis?
I know recurrent pleural effusion is an indication.
Pleuritis. When will you fuse somebody's pleura?
When it's recurrent.
Exactly. So what is the answer?
Recurrent.
Recurrent pleural effusion. That's the only thing you right? Okay. Loss. I want you to match the cells with. So neutrophilia is what? I can skip it. So we do elimination if you're not sure. You want to skip? Okay, subphrenic abscess, and eosinophilia will be eosinophilia.
Did you say, I remember you saying for some weird, rare reason.
Pneumothorax.
Yeah.
Lymphocytosis.
That'd be.
This is a malignancy? Right? I mean, I'm asking you.
Yeah. B.
B. Mesothelial cells.
Isn't this a criminal
What? Okay, Stephanie. Mesothelial cells. Nephrotic syndrome, yes. That's the answer. Red blood cells.
No, hematoxylin.
Why are you guys always making the exception the rule all the time? Why do you do that? You know, you never make the only exceptions are exceptions. Right? Exceptions are exceptions. I told you, I even made a comment that for some odd reason, when people have hemothorax, post-traumatic, they tend to have eosinophilia, right? But here I give you a question, and in the question you see drug-induced effusion, that means it's probably an allergy, and you see red blood cells, and you have to choose between hemothorax and drug-induced, and you put eosinophilia with hemothorax. But what?
But if we put them for both, technically we wouldn't be wrong.
Technically, yeah, but in reality,
Yeah.
You never win, dude.
No, actually, my exam questions are not this complicated. I just put these complications there to kind of let you know that, please, one of the commonest mistakes you make is to make exceptions rules. So when you know that this could be an answer, you look for a better answer. Only when there isn't a better answer does that become a true exception, and that becomes a true answer. See, the idea is to help you understand that exceptions are exceptions all the time, and you have to treat them as such. Okay? Huh?
Let's go through one time.
So neutrophilia is drug induced. I'm sorry, schizophrenic abscess, right? Eosinophilia is allergy, drug induced. Lymphocytosis is malignancy. Mesothelial cells is nephrotic syndrome because it's a transudate, right?
Yes.
And red blood cells is hemophilia.
What you say about mesothelial?
Because nephrotic syndrome is a transudate. It doesn't cause increased cells. It will just increase the volume of the pleural fluid. The cells will be still be the same. The cell proportion will be the same. Right? Okay. What percentage of patients, oops, it's after 11. What do you guys have?
It's okay, we can finish.
All right. What percentage of patients diagnosed with mesothelioma survive for 5 years? Less than 8%. Which of the following statements about neoplastic diseases of the pleura is correct? Secondary tumors are more common. Malignant pleural tumors are more common than benign. Bronchogenic carcinoma is the commonest cause of secondary. Mesothelioma is the commonest malignant pleural.
All of the above.
All right, Wendy. So these are some patients. What would you do? So here is a 36-year-old healthy keyword, healthy male with a small asymptomatic pneumothorax. Exactly, that is the one you watch and wait. Okay, it's spontaneous and it's primary, right? 56-year-old breast cancer survivor with recurrent pleural effusions. Exactly, you use that pleural. 42-year-old male asthmatic with an asymptomatic pneumothorax. You will. What did you say? E or E? E. Okay, you will authorize this patient, right? 60-year-old female with a significant asymptomatic pneumonic effusion on admission chest X-ray. Good. Diagnostic, you tap the effusion to find out why it's happening, right? 78-year-old male smoker with severe dyspnea and hypertension shortly after a prolonged bout of cough. Emergency nasal aspiration, right? Good. So you see the difference in this set of questions between primary and secondary pneumothoraxis, right? Mm-hmm. Good. Good, you're doing very well. Which of the following activities is prohibited in the immediate discharge period after hospitalization for pneumothorax?
All of the above? All of the above? Bowling balls?
A bowling ball.
They're heavy. Bro, they're heavy. They're like 10 pounds. They're still 10 pounds. Bro, they're like 10 pounds. What are you playing with the kids? No, they're like 10 pounds.
Bro, either way, you gotta get on the plane and do bungee jumping, right? No, that's parachuting, my bad.
No, but bungee jumping is like...
I was like, you gotta get on the plane, hold on, that's parachuting.
It's just the pressure change.
Let's say we can't agree.
Yeah.
Wait. Let's say...
What happened?
Okay, we're good.
Let's say we can't agree on bowling.
Okay.
But we all can agree on scuba diving.
Yeah.
And we can agree on bungee jumping. What is this?
Bungee.
Yeah, what's bungee? Like Al Bundy?
Al Bundy jumping.
You want to jump out of the plane?
Yeah.
No. That's parachuting.
Bungee jumping is right next to the thing and you jump
Oh,
off.
yeah. Oh, bunt, the other is bunt. It's bunt. That's why you're laughing. You're all evil.
I know what you're trying to say.
Okay. All right. Hey, let me tell you something. If I even make you think I still decide what is the right answer. Better be nice. Sorry, bungee jumping. That's what I mean.
Bungee.
Spell it.
B-U-N-G-E.
Bungee. All right, thank you. Bungee jumping. So we're gonna call that man Mr. Bungee.
Get together.
Bungee jumping, I think.
Hey.
All right, okay. Moving on.
Hey, we can get together and jump out.
Randy, you're gonna answer all the next questions. You even should get that. So, which of the following is a potential complication of an aggressive treatment of a large subacute pneumothorax with a long-term lung collapse? What will happen if you treat pneumothorax aggressively?
Do it too fast.
Yeah.
That edema.
Yeah, what is it? Tell me the answer.
Pulmonary.
Okay. Bradley, which of the following indices is an indication of a small pneumothorax?
All above.
Good.
Thank you.
Nice. Al Bundy.